welcome everybody. We're going to jump right in. We have a full slide deck here, a lot of content to go through, and I hope that folks had an opportunity to grab that readiness guide that we had a link very close to the registration link for this as well, because we'll be going over some of those key highlights from the readiness document here. Okay, so before we get started, I'm going to roll out a quick little poll just to kind of get an idea of where everybody is in terms of their knowledge and readiness for the No Surprise Act. So how prepared is your organization for these No Surprise Act provisions? We've got option A, which is you guys are solid, you're fully prepared. B is, we're working on it. We know the requirements and we're making our changes. C is, yeah, we haven't really quite started yet. And D is help. We're not really sure where to start, where to go. We know that we have a big mountain to climb here. So I'm going to give folks just a few more minutes. Okay, or not minutes, excuse me, a few more seconds here. I'm waiting to see if we get about 75% participation. So we're gonna drag this out until you push that button. A few more seconds here. Okay, excellent. Okay, fantastic. I'm going to go ahead and close that up here. So 73% of you folks are actively preparing for the requirement, and 5% of you guys are solid and fully prepared. Fantastic. We've also got about, well, let's see if I can do my math here, 23% that need a little extra help here. Maybe we're not really sure where to start. So that's what we're going to be going through today. We're going to give you some excellent resources. But first, I want to start out with this is not new to several of our states. So there are many states, and they're the folks that are represented here in green, whether you have a partial or a comprehensive law, but they already have patient balance billing protections in place. Now, there are various levels of them. California, for example, is very stringent and reads very closely to the federal law that just went live this year, but their balance billing protections went into play around July of 2017. And so these have been around for a while and are not necessarily new for some of these states. But one thing that I want to show is kind of a comparison. So this is Oregon State, for example, and they have had protections in place for a couple of years now, but you can see on the left-hand side here in kind of the red color, this is kind of a high-level summary of the protections that they have in place. For example, it just covers your HMO or your PPO commercial plan enrollees. It is only covered for out-of-network professional services. They do have a standard payment calculation in their law, and it also has a consent process. On the right-hand side here, you can see that there's way more provisions built into the federal law. For example, all commercial plans, including self-funded, are covered in the federal law. It also includes all types of care, whether it's emergent, specific emergency, air ambulance, any kind of care for a provider or facility. There's also a payment determination. So they have indicated, CMS has indicated into the law, a way to calculate reimbursement for out-of-network payers. But then it also says if there is a payment standard for the state law, you can default to that. Both of them have a consent process, but then in these last three bullets, we really get into some extra details for that federal law. We've got a dispute process, we've got some good faith estimate requirements, and then we also have consumer notification requirements as well, which we're going to dig more into those details throughout our presentation here. So what qualifies as surprise billing? So this is the definition that was rolled out under the federal law. It's when a patient unknowingly receives care by an out-of-network provider or facility. Now this includes services at an out-of-network facility, certain ED post-stabilization services. So it's not when the patient arrives at the ED, it is after they are stabilized, and there's certain criteria that must be met for them to fall into that category, and it's all spelled out. It also includes air ambulance services. And then another example that is kind of confusing, but this is probably where most of the surprise happens, is an out-of-network provider, but they're in an in-network facility. So say they have a contract to work at that facility, but that provider doesn't have a contract with that particular insurance company. And one good example of this is anesthesiologist groups. And so you've got a patient, maybe they have scheduled a visit, it's an elective procedure. They know that the surgeon, their provider is covered, they're in network, the facility is in network, but they may not be aware that that particular anesthesiologist group is not contracted with their insurance. And so at the end of the day, when they receive their bill, it's going to be a higher out of pocket for them because that claim processed at a lower percentage. Okay, so this next slide here is just kind of a quick summary. This is what the No Surprise Act is starting the first of this year. It is going to ban all patient billing for out-of-network services. So that, like I said, includes emergency, air ambulance, and services provided at either an in-network facility if it's a provider, or if it's an out-of-network facility altogether. Patient cost sharing cannot be higher than in network. So when the patient receives that EOB, the way that it should be processed by insurance companies is as in network. Now, the only exception to this is there is a consent process, which we'll talk about a little bit later on, but this consent allows us to bill the patients for their out of network. It also allows the insurance to process as out of network, okay? This law does require providers to inform the public, and we'll talk about what that bulletin has to say or how that information has to be provided. Out-of-network payments are to be processed by the insurance company and paid out at what they're calling a median in-network rate. Now, this is the only caveat to this is if there is reimbursement methodology built into the existing state plan. The federal law reads that you can default to the state plan. If there isn't, so for example, for Alaska or Idaho, where they didn't have provisions in place previously, then you would go with this median in-network rate. And what that means is they're going to take all the payers are going to take all contracted reimbursement rates over 2019 claims data. They're going to find the median reimbursement rate for that, and they're going to apply it to out-of-network claims payments, indicating that that is an in-network payment. Okay. This act also puts into place a formal dispute process for both providers and for patients. So it's built in at the federal level, a way for patients to dispute. And there's certain information that they can dispute, and we'll get into that in just a minute, but it builds in that protection for them as well. So the out-of-network definition, just kind of a reminder for you guys, what is out-of-network? So basically that's when a hospital, clinic, or provider does not have a contract with a specific insurance. Or maybe the hospital has a contract, but the provider doesn't. So the provider that's working, maybe they're a traveling physician, anesthesiologist group, maybe those folks, they work at that facility, but they don't have a specific individual contract with Premera, for example, like the facility does. And why does this matter? So out-of-network claims are processed at a much lower benefit level. So typically you see 80% of the allowed charges is the level of benefit that the insurance will pay. 20% of allowed charges is what gets passed on to the patient. And that's an in-network processing rate. When you go out of network, it looks a little bit more like 60-40 or sometimes even less. Sometimes, depending on the plan, the patient doesn't have any out-of-network benefits. So it would be a 0%, and that entire balance would then be pushed onto the patient for the out-of-network. So part of this, a large part of this, does lie on the shoulders of the payer. We need to make sure that the payers are processing these claims appropriately. So we're hoping that their adjudication systems are going to be updated so that these claims will pass through and process in an in-network rate, and we don't have to go back and forth with them to make sure that the patient balance is correct per the EOB. So all nearly health plans are affected under this new law, which means your ERISA plans, your self-funded plans. In fact, the only plans that are not covered under this new law are your fee-for-service. So Medicare fee-for-service or your state Medicaid fee-for-service. Those are not covered under this, but the managed care that is attached to those fee-for-service absolutely are covered under this plan. All emergency department and air ambulance services must be automatically processed as in network. And that's what I was talking about, how the claims have to adjudicate at the payer level appropriately. This is not something that as a provider we need to push and have the insurance company do. It's supposed to happen automatically. Out of network is going to be reimbursed at that qualifying rate. It should look like an EOB that comes from an in-network insurance or provider, and they're not supposed to require prior authorization for emergency department and air ambulance services. They can't require that. The payment or notice of denial has to happen within 30 days from the plan receiving that clean claim. Now, this law is built in, or this provision is built into several state laws where they're required to push on that payment or respond in some fashion within 30 days from that clean claim. This just gives us a little bit more leverage from a PFS perspective. So this is just another layer where we can push and make sure, because now it's at the federal level, that they need to respond quicker. Plans can extend that processing time frame up to 15 days if they need additional information, say an itemized statement, medical records, a primary EOB, for example. but routine denials are not allowed. So when we fast forward towards the end of our presentation here, we're going to talk about some reporting. And that reporting, we want to make sure that we're including denial reporting, and we're watching it very closely because we're sure that we're probably going to see some blanket denials happening, and they're specifically not allowed to do that. So again, this law does give us a little bit of leverage from a claims follow-up perspective. And then this last bullet, I don't know if you've ever tried to chase down payment from a patient, but this is really good news that the insurance companies are required to remit that payment to the billing provider and not to the patient or subscriber, which is good because it's very difficult. And a lot of times it's kind of take that money and run situation. And it's hard to get that payment back from the patient. Couple of other requirements that the insurance companies have under this law. One of them is called an advanced EOB, and this goes hand in hand with the requirement of the good faith estimate that the providers have to do that we're going to talk about in just a little bit. But what this advanced EOB is in essence a mocked up EOB for a potential scheduled service. So if the patient would like to shop around and see which facility they want to go to for an elective procedure, they will get a good faith estimate from that provider, and the provider will then forward all of that estimate information to the insurance company. The insurance company is then required to produce within 1 day an EOB that looks very similar to an EOB as if the services had actually happened. It needs to include all of the provider bill charges, allowables, cost shares, patient's responsibility, current standing on deductibles. It's going to be a really robust EOB. And if the provider that has sent the information, has sent the estimate to the insurance, is an out-of-network provider, the insurance is required to include in-network provider information. So if the facility is a participating provider and they're in network, it will indicate that on the advanced EOB. If they're not in network, it will also indicate that, and then it's required to provide some resources so that the subscriber can find a provider that is in network should they choose to. It should also include any applicable disclaimers. Now, it's important to note that the advanced EOB is actually on hold. We have not seen when this is going to be required to go live. It was supposed to go live January 1st of this year. However, payers were pushing back and they were not ready to produce this. And so the advanced EOB, last I read, is probably going to be a requirement around the June or July timeframe later on this year. One of the things that did have to start as of January 1st of this year for the insurance is additional information on member ID cards. So if you've gotten your ID card, you may have noticed that the font is very small because they've had to cram additional information on there. So they all now have to include the in-network and out-of-network deductibles. They have to include out-of-pocket maximums, and then either on the front or the back of the card, usually the back of the card, it has to have additional resources for the subscribers in order to find in-network providers, a contact number, a website, some additional disclaimers or information. So I personally have gotten my card and I notice it is quite a bit smaller. They put all that information on the front of the card in terms of deductibles and what it would look like if I went to an out-of-network provider. So that was really good. And it's all about educating the subscribers, educating the consumer so that they can make that decision on where to go and not have to pay for their more than they need to for their services. So rolling over here into provider responsibilities. And so the list is a bit smaller for the providers, but then at the same time, we need to make sure that the insurance company and the EOBs are being processed correctly. So there's a little bit more responsibility that's not written out in the law, but we're in revenue cycle and we know what we need to do here. So in terms of the law, we need to provide a good faith estimate. Right now, it's only for uninsured and self-pay patients. So just like the advanced EOB is on hold, providing a good faith estimate for insured patients is also on hold. So that's probably going to go live, I would say, June or July later on this year. So we're going to look for some additional information, additional final rulings from CMS on this one. But we do need to provide that good faith estimate for all of our uninsured and self-pay. And self-pay is defined as any patient that is looking to pay out of pocket for their services, whether they're insured or not. We also have to provide a notice of rights to consumers, and it needs to be a separate document away from all other consents and all other information that we provide to our patients. It also has to be posted on our website. And there's lots of information out there from CMS. They actually give you not only guidance but some verbiage that you can use on their website. So that's a really good resource. But that information has to show how your facility is abiding by the consumer protections, and then also where are some resources should they want to find an in-network provider, find more information on that, or if they want to make a complaint. And I'm actually seeing that the price for anybody provider in non-compliance is around $10,000 per event. Okay. Now, not written out in the law because this is actually optional, is developing a workflow for the consent process. You're not required as a provider to use the consent. However, if you want to bill patients for their out-of-network cost, if you want those claims to process as out-of-network, you have to have that consent in place. Okay, we're going to go over the consent in a little bit more detail because it's very unique in the wording that they used. It's also provided by CMS. So we'll go over that in a second. And then lastly, it's good to implement that workflow. Now, it's not required. It doesn't spell out that we have to implement a workflow, but we are required to make sure that that balance that we're passing down to the patient is appropriate and it's shown as in network. Now, we have to process and we have to push the balance to the patient based on our EOB. We always want to follow that EOB, but it's up to us in the business office to make sure that those amounts are correct on the EOB. If it's not correct, we got to push that back to the insurance company. So now let's roll into reimbursement here. So I've kind of oversimplified this, and I've got just a couple of scenarios when we're receiving payments by out-of-network insurances. And now remember, they're supposed to be processing these claims out-of-network. They're supposed to be processing them as in-network. So in our first scenario here, we're going to agree with the payment amount. So we bill the claim to the payer. They receive it. They have 30 days to respond. They can, like I said, extend another 15 days if they need additional information, and then they're going to remit that payment to the provider. That payment is considered payment in full. It's supposed to go directly to the provider and not the patient. Now, this is where the clock starts ticking for us. As you can see right in the middle of our page here, we have a big red line. I'm kind of calling this the risk area. After we get that payment from the insurance company, we only have 30 days to look that over and start to negotiate if that payment is not correct. So we only have a very small window in order to react to that payment. And because the payment is not tied to what we're used to seeing as an out-of-network provider, it's tied to in-network median rate. And there could be some folks in that network or contracts that do not have a very good reimbursement. And so we may end up getting underpaid for some of these. So it's really, really important that you're on top of these payments and making sure that you're going through them, double checking that you're being paid appropriately, and then pushing back if you feel that that payment is way under what you're used to seeing. These could also be paid under usual and customary, and sometimes the negotiation can be sent via fax and misplaced. I'm over here in this risk area here. So here's some things that we need to worry about. If they send that payment over and the EOB is incorrect, if they send the payment over and we don't get to it, then you could miss out on an opportunity to negotiate for a higher paid amount. Day 31, it is assumed that the provider has accepted that payment. You got to post it, you're out of resources, and you can't push back. You can try with the insurance company, but in terms of the independent dispute resolution process, which we'll get into in a second, you really don't have a leg to stand on because it is built in to just be 30 days. Okay, so now how do you know if the claim has been processed under the No Surprises Act provisions? They have created 3 remark codes. These are ANSI standard remittance remark codes. And when I say remark, I really mean like the 3rd level on that 835. So your first level is going to be your group code, and that's going to be your PRs or your OAs or your COs for contracted obligation, things like that. Your second level is going to be your reason code, and that's where you get like your 45 for contractual and 97s for bundling. And then nested under that, at that 3rd level, is where you get your alphanumeric remark codes, which usually give you the information that you're looking for. So the two top codes, I would assume, are going to be assigned probably next to the 45, probably a CO 45 to indicate that this is a payment and the rest is going to be an adjustment. Whereas that last code, in my mind, speaks to your patient responsibility. It's probably going to be coupled with a reason code 1 or 2. Okay, these codes went live, as you can see, on not February, excuse me, on November 1st of last year. And so we're hoping that they've been built into the adjudication system. Keep an eye out for any of those paper remits if you're not getting an 835. So these are ANSI standard, so they're required on the 835, but they're not required on your paper remit, and you could still see some proprietary codes. So like in our readiness guide, I've suggested creating that crosswalk for your cash posters so that they can post these in a way that you know that your billers know that this is a claim that was processed under the No Surprise Act provision. Okay. So this next scenario, I'm going to warn you, this is a really busy slide. This is what happens when you disagree with the payment. So you've received the payment on that claim. It is drastically underpaid based on the payments that you are used to seeing. It certainly doesn't cover the cost of the care, and you want to push back. So in the very beginning here, like I mentioned, we have a 30-day window where the payer can get the claim and remit their payment. Then you have another 30 days to negotiate with the insurance company to say, hey, this is underpaid, this is the reason why, and you can go back and forth. During that negotiation, if you are unable to come to an agreement that both parties are okay with, then you have 4 days to submit a formal request for a independent dispute resolution entity. So at that point, you have to notify the payer and you say, okay, we're not going to come to a consensus here, and so I want to bring in an outside entity, a neutral party, and you have 4 days to notify them and then decide who your entity is going to be. And there's a list of them out there. They had to actually enroll with this federal program. There was a link, it's through CMS. There's all this information where IDR entities can be signed up. So it's a very small window for you to choose that. Once you've chosen your IDR agency, then you have 10 days to send over all of your documents to that agency. And there's a list of things that are required to send, and then there's other things that you may want to send in order to support your payment amount. You're going to be doing that as a provider. The insurance company is going to be doing that at the same time. And then the IDR has 30 days to either ask for more information or process what that looks like. And then they're going to submit a written notification to both parties, and that is going to be what the payment amount is going to be. And that's it. So we'll get into more information in just a second on that IDR process. But once they have determined what that payment will be, and the IDR entity is not required to go with either amount. If they do, maybe they meet you in the middle between both amounts, they do have to provide the rationale as to where they came up with that amount, but they are not required to choose one or the other, okay? And then this last one here is called the cool off period. So basically, whether you win or lose as a provider, you have to wait 90 days to go after that same payer for additional disputes. And so you want to make sure that you are packaging these up, and you can bundle up multiple dates of service, multiple claims. Say there's a trend that you've experienced, you can package those up and you can go into one IDR process with that package, but then you will have to wait 90 days. Now, during that 90 days, you can continue to negotiate with that insurance company on the side, outside of the formal process. You can continue to do that. You can also package up those claims that are occurring if they're being underpaid. Once that 91 days hits, then you can do another formal IDR process if you want to. So it's not like you're missing out on an opportunity for 90 days. You just can't continue to go after that same insurance company month over month. They're putting in that 90-day window along with all of these stops in place because they're hoping that the providers and the insurance companies will be able to resolve these payment issues outside of this formal process. Okay. So let's talk a little bit about the provider requirement for the good faith estimate. So I talked a little bit in a couple of slides ago, but just a reminder that it is delayed for insured patients, but the requirement is still in place for uninsured and self-pay patients. Your good faith estimate must include all of the patient's demographic information, so what they would register with, description of services, including specific codes, actual dollar itemization of charges. So if this is a procedure, even though it's typically paid in a bundled rate, you do have to line item out all of those charges, and then be sure to include any disclaimers in the event that there are other providers that may come in, an anesthesiologist, or in the event that surgery, we need to do additional procedures. Once we get in there, it may cost more. You want to put all of those disclaimers in there. This next section here, the patient-provider dispute resolution. So this is a formal process where the patients can ask for a neutral third party to review their out-of-pocket cost. So the way that this works is it's tied to the good faith estimate. So we'll give an example here. The patient goes in, they request a good faith estimate, they are uninsured, they want a certain elective procedure, they get the estimate, it says they're going to owe $1,500 at the end of the day. Great, they move forward with the procedure, they get their bill, it's actually $2,000. Because their bill is more than $400 greater than the estimate, that patient now has an option to initiate a federal dispute process through a patient IDR portal. It's going to cost them $25, but they can have a neutral entity review all the information and then decide what that patient's out of pocket would be. The thing to remember about this is the patient has 120 days. So they could go all the way to the final notice through their self-pay statement cycle before they have to, before they are running out of time to do this formal dispute process. And so this could come at any time. Once the information is provided from the patient, likely that IDR entity will also reach out to the provider to receive additional information, and then they'll have 30 days to decide what that patient's out of pocket is. And really the power lies with that IDR entity. And they may very well decide, in that situation that I gave earlier, that instead of the $2,000 the patient was billed for, the patient's actually only going to owe the $1,500 estimate that they received originally. Okay. All right, moving along to consent forms. So out-of-network consent forms, like I said, it is optional, it is not required, but if you ever want to bill the patient for out-of-network, if you have a high demographic of out-of-network patients and you know that you're going to receive reduced cost for them, for the claims to process at a median rate, then you may want to implement these consent forms, but there are some guidelines. So your consent form has to be provided within 72 hours before the services are rendered, and that's in a scheduled non-emergent situation. Because the No Surprises Act provisions actually cover emergency department situations after the patient has been stabilized, you can also issue an out-of-network consent form to that patient once they're stabilized. There's very specific language in there on what is considered stabilized and when it is safe to provide that consent form, but that is also an option that you can do. It has to be a separate document. It's approximately 3 pages, and I'm going to go into the document in just a second. And it has to be separate from all of the other consent paperwork. So all the other paperwork that you have that patient fill out, electronically sign, all that good stuff, it has to be an entirely separate document. Now, how the insurance company, so say you secure a consent form, how am I going to let the insurance company know I have a consent on file? Please process this at the out-of-network rate so that I can bill the patient the appropriate out-of-network amount. That's still pending. I just the other day looked at United Healthcare website. I looked at a Blue Cross website to see if they had any guidance on there, and it was very high-level information on this act. And so we still don't know how we're going to let the insurance companies know, because as you know, most of these are billed electronically. If it's billed paper, you could probably attach the consent. But if it's billed electronically, it's going to be difficult to get that consent to be attached because normally you can't send paper attachments along when you electronically file your claims. So this is kind of up in the air, kind of TBD on this one. So let's dig into the surprise billing protection form. Now, this is the consent form, and I'm only going to show this really quickly because there's a couple of items on here that I think it's important for your folks to know, and why it's really important to, even if you're not going to go through with a formal consent workflow, making sure that your patient-facing staff are even aware of what this is, because this language is very different. Now, when we first read about it, I thought, oh, well, it's very similar to an ABN. It informs the patient what they could be liable for, and then they sign, what their options, they get to choose a couple of options. Yes, absolutely. But then they've got some terminology in here like getting care from this provider or facility could cost you more. And then there's this next page here, which is a lot of fun. So the first bullet here, it says, I'm giving up some consumer billing protections under federal law. I may get a bill for the full charges. So when you have information on there, and I think for those of us that are in revenue cycle, we can appreciate medical billing is complex. It's very tricky. It's very difficult to understand. And we're fortunate that we're in this industry so that we know what an EOB means and we know what this consent means. But the language that is in here for your typical patient or consumer could be a little scary. It could actually be a little unsettling. And so it's not like a legalese document like the ABN. This one is it almost feels a little more personal. And so it may be difficult for patients to want to sign this. And it's 3 pages. So you've got that first page in there with kind of some scary language in terms of from a consumer standpoint. And then there's the second page where they're saying they're giving up all sorts of laws and protections and they're not really sure. And then we have our third page here, which is going to be kind of a heavy lift for the providers, where we have to provide an estimate. So not only do they have all this information about things that they're giving up, but then we have to provide an estimate of what that out-of-network benefit level will be. This is what your out-of-pocket could be if you sign this form, which is a lot. It's a lot to go through. It's a very heavy workflow. And I understand the benefits that we are educating our patients and the consumers out there, but it's good if you want to implement this workflow. But once again, at least make sure that your folks are familiar with this, because this is an interesting form, honestly. Another thing that you'd want to do to prepare your folks is handling patient questions. So this is a slide that we have just gone over just this week with our internal team, especially our self-pay team, that just because the patient was surprised by their bill, it does not mean that it's against the federal law. And this is really important. Make sure that self-pay, patient-facing, anybody that could potentially talk to a patient about a bill or even talk to a patient in general, make sure that they know about this. We expect a high level of consumer confusion. Like I said, medical billing is confusing. It's convoluted. A lot of people don't understand why claims process the way that they do. They're not going to understand what this out of network means. And so we do expect a lot of questions. And also, this went into place at the same time that deductibles have reset. Benefit levels may be different. So maybe the insurance that you're used to from 2021, that benefit level, maybe it's different in 2022. So you're surprised that your copay is higher and you think it maybe falls under these provisions of the law. And most likely it won't. So it's important that we look at our EOBs. We want to carefully review them, see how the claim processed, check for those remark codes. Does this even apply? Was this claim even processed under provisions under this law? There's your remark codes right there. Are they on that claim? How was it processed? Does it say there are unique remark codes also used when a claim is processed as out of network? Are those on that EOB? If the claim processed is out of network, is there a signed consent on file? If there's no consent on file, the EOB clearly states that it was processed as out of network. You want to pull that account back and you want to make sure that your billers take a look at it again. The insurance company needs to reprocess that claim, reprocess it, and make sure that it's done appropriately so that your EOB is correct and it matches the statements that you're sending to the patient. If the claim is processed at an in-network rate and the patient is still concerned and they're saying, no, I usually only pay $20 and now I'm being billed for $50, then always recommend to contact the insurance, because it's the insurance company that's going to know that benefit level, or the employer. They could always go back to their benefit booklet and they could check and see if maybe their copays or their out-of-pockets have increased based on what happened with their January 1st, 22 insurance, because things can change once the new year begins. Okay. All right. So that's probably like the biggest. Just because the patient was surprised by their bill does not mean that that the provider is not in compliance with the federal law. So now we're going to roll into readiness, and hopefully you got that document. I do see that Molly also pasted that link in there, which is fantastic. So we've got a PDF that kind of gives you some information about the No Surprises Act, just a super high level overview of what we just basically talked about. And then it talks about how to get yourself ready. So I'm just going to go through, I've pulled a lot of that information that we're going to go through from that readiness document. So let's just jump right in there. So the first thing that you want to do is identify your risk. So as a facility, as an organization, identify your risk. How much of this No Surprises Act actually applies to me? Check and see if you've already had state balance billing protections in place. Maybe you've already built in these workflows. Maybe the workflow that you have from the state is more stringent, so you can ignore that part of it in the federal guideline because that is just the requirement. So written into the law at the federal level says if you have something at the state level that includes XYZ, then go with that, default to that. So basically what is more stringent. So once you've determined that, yes, we don't have anything in place, so for those states that don't currently have anything in place, what kind of information or what kind of registration do you have? Do you have a lot? Do you have a high volume of commercial patients? So obviously you still need to do the posting. You're still going to need to do the good faith estimate. But when we talk about the IDR process, when we talk about reimbursement, are we at risk for losing out on money? That's when you want to look at your registrations. And I would look for a year's worth so you can have some of that seasonality. Maybe go back a couple of years because things have kind of blown up a little bit with COVID. Maybe you've seen a lot more patients in the last year than you normally would have. So maybe go back to 2019 data and compare that and take a look at it. So how many commercial patients did you see? That's going to be in your registration. Were they primary? Did you have a lot of secondary commercial? So now we're talking about a higher volume perhaps of secondary commercial at a network, but maybe it's the balance is after Medicare, for example. So it's really going to be a smaller risk because it's a much smaller dollar amount. And then take a look at your reimbursement trends. How many of your claims actually processes out of network? And they do have some ANSI standard codes that indicate that it has been processed out of network. So you want to take a look at that. And that's just so you know what your sense of urgency is and how much you need to go into doing training and creating workflows. Okay. So your step 2, once you've assessed the risk and how much volume that you have for out-of-network and commercial patients, you want to start developing and documenting workflows. It's important to document these workflows because that's going to ensure consistency and it's also going to increase accountability. So on the front end, and these are going to be all your patient-facing folks, registration, arrivals, admitting, your folks in the ED. You want to make sure that they're comfortable with everything that's going on. You want to develop a workflow for your good faith estimates, which is what we need to provide to uninsured right now. Part of that, and a big part of that, is going to be, and this could be for your financial clearance folks, your verification of if that patient that is either scheduling or has arrived, are they in network? Are they out of network? They can find out that information using real-time eligibility. You have to make sure that you scroll down. That's one of the things that's kind of like my knee-jerk reaction. When somebody says real-time eligibility, I go, you got to make sure you scroll all the way down. That's where you find your managed care information. That's where you find your in and out of network information. And then also what that patient's benefit level is for out of network. Because if they have a specific plan, like an HMO plan, there is no coverage for out of network. And so it's important for that patient to know that. And then also, if you do choose to use a consent to bill out of network, you got to make sure you're scheduling, financial clearance, arrival, admission, all those folks that see those patients when they walk up or when they're scheduling, you have to make sure that they have a workflow to administer that consent and answer some of those questions if the patient gets a little concerned when they're reading through that information. Because like I showed you in that consent form, the language is very different from what I've seen on other consent forms. So they need to be able to answer those in a confident way. On the back end, timely responses to your claims. And so when I'm thinking about that 30-day window, so you may need to adjust the way that the work is delivered to your billers. Usually when you receive a payment, there's probably going to be a little bit left over, probably a lower dollar balance. Those tend to get pushed out. You're not going to touch those. Maybe it's a $500, $600 balance left over. You're probably not going to touch those on the hospital side every 30 days or every 2 weeks. So you need to make sure that you have some sort of workflow so that the billers can see these because they have 30 days to respond if it's been underpaid. Decide if you want to do the IDR process. Does it make sense based on how many commercial claims we have, if we have claims that are underpaid? Now remember, there is no requirement to start the IDR process at the beginning of the year. You could see through reporting, how are my claims being processed? It's still early enough to where you could develop some reporting and just really keep an eye on it and see, does this make sense for my time? Is the juice worth the squeeze for me to go through this entire IDR process? I mean, you saw that workflow. It's very heavy, it's labor intensive, it's timing. So if you miss out on a deadline, then you basically have to you're stuck with that payment. So if it's something that's worthwhile, then you want to make sure you document that workflow. And you may need to designate some staff to handle that. And so if you have a very high risk, you could miss out on a lot of money over the year as you're receiving these claim payments, then you may want to designate some staff, some specialized staff. Maybe you have a denials team. Maybe this denials team is kind of a layer above your standard billers, and these folks are competent enough and they work really fast, and you want to have those people do this IDR process. You want to make sure that you're validating patient out-of-pocket amounts. So that's going to be part of timely response to claims that are paid. So these out-of-network claims, you may need to put an edit in place or some sort of a stop. So if it processes through and you have a post on there or a reason code on there that says this was processed as out-of-network, maybe that needs to act somewhat like a denial and get pushed over to somebody that can double check it. I have a consent on file and this patient responsibility is legit, and then send it off to the patient. So that would be a really good workflow, because like I mentioned, each one of these violations, each patient is going to be about $10,000 is what I was reading. And so it would be good to make sure that you have that process in place. Make sure that you have education and lots of scripting for self-pay staff. So it's important that they feel confident, because that's the biggest way to get that call escalated. I need to talk to a supervisor or get that patient upset, is if the response they're receiving on the other end doesn't feel confident, like that person doesn't feel educated. So think about when you have a concern with your internet bill or your cable bill, and you call up the cable company and you're talking to somebody that really doesn't sound like they know what's going on. Then you're going to want to talk to somebody else. Your frustration level escalates. So making sure that those folks are confident through education and scripting is going to be your best bet. And then also a workflow for additional review of the claim and patient balance. So this may, if you don't have this built in to your billing staff, then you may need to roll this into the self-pay staff. I would definitely do a double check to make sure that that maybe based on reason code, when you're trying to pull your statement files and things are going to go to collections, you may want to have another look at that as well, because it's amazing how many patients respond after they receive a final notice or they've received that first statement from the bad debt agency. And that's just going to cause a lot of administrative burden. You're sending it to the bad debt agency. The agent, they get a call from the patient and they say, hey, and by the way, this wasn't even processed appropriately anyway. I'm going to make a complaint. And so try to kind of work proactively in that manner and see if you can set up some filters in place, so that we're making sure that we're billing the patient appropriately. Okay. Just a couple things to think about, and this is tied to the independent dispute resolution process. So some things to keep in mind. If you want to do the IDR, you're thinking about doing the IDR process, one thing to think about is there's not a lot of wiggle room. So like I mentioned, you're going to submit all of your information to the IDR entity, and then you just wait. Now, during this process, you are allowed to negotiate with the insurance on the side, but you've already entered into the IDR process. And so once they have made their ruling, then that's it. That is the payment that you are going to receive. That is the payment that you will accept. There is no additional negotiating or pushing back with the IDR entity. Okay. And there's also a cost. And so for each one, each IDR that you enter into, there is an administrative fee that is required by both parties. It's $50 from each party. And then the non-prevailing party has to actually pay for the independent dispute resolution entity. So the cost of their time. And it's anywhere between $200 to $500 every time. So if you're using an IDR entity, or the insurance likes to use a particular IDR entity that charges $450 each time, and then you have that $50 administrative fee. If you are not successful in winning that dispute, you will have to pay $500. And if you're pushing back on a claim that was underpaid by $360, then it just doesn't make sense. And so those are some of the things that you want to keep in mind when you're trying to make that decision on whether or not you want to do this whole entire IDR process. And then also the cool off period, which is really just kind of an administrative burden, because you want to push back. If you're successful pushing back, you're receiving those payments, that's great. But then we have this cool off period where you have to then collect and keep track of claims that need to enter into an IDR process again. And so that's just something to keep in mind. And if the cost to go through this process, whether it's salary because you had to hire a separate person to do it, or whether it's the cost of the actual IDR entity, those are things that you want to consider, because there's also that 90-day time frame. And so the law has not made it very easy for us to push back with the insurance companies. Okay. So now let's talk about training. Okay, so we've talked about workflows, we've talked about risk, and so we're tracking right along. We've developed our workflows. We know what we want our teams to do. So then how do we roll out the training? This is also in the readiness guide, these neat little, kind of steps and check boxes for you. So how to train your folks, we've broken it out into 3 separate sections. So we've got our front end staff. We want to make sure, just generally speaking, for each one of these groups, they need to know what the No Surprise Act is. What is it? High level. I mean, you can take this presentation that we're doing today. We're going to share the link with you guys and also the slide deck. You could even have them go through this, take this webinar, and that would work out great. They need to understand what that means for them. And also from a personal standpoint, from a patient or consumer standpoint, this really affects all of us because there are in-network and out-of-network providers all over the place. So it's good. It's good for them. Review some RTE responses on out-of-network payers. Make sure they know how to look at those responses. Show them some examples. Click into your real-time eligibility system. Make sure they know to scroll all the way down. Even though your front-end staff are probably using this on a daily basis, you'd be surprised how many people could use a refresher. Just ask your billers who are always doing those registration, coverage updates. The front-end folks could always use a refresher. There's nothing wrong with that. Make sure they know how to read insurance cards. Talk to them about the new requirements and the new information that needs to go onto the new insurance cards. Where do they find that information? So coupled with the RTE, how can they read through those insurance cards? If they know how to read those insurance cards, then it will be a much easier conversation with the patient when they walk up and they have to hear that, oh, it looks like this provider is out of network. And maybe the patient doesn't know what that means. So having, once again, that confident conversation. So teaching them how to read those insurance cards and what all that means is gonna save you a lot in the long run. Walk through all of your documented workflows. If you choose to do the consent forms, your good faith estimates, walk through the posted requirements, so the public notice, in case there are folks that walk up or folks that have questions. Make sure that they're aware of that notice and what that means. And if the patient has concerns, what resources can they provide? Make sure that you walk through all of that so that your front end folks feel comfortable answering those questions. Review the resources that maybe the patients have seen. So there is a really nice packet that CMS has put together. It's geared towards beneficiaries and really just the general public. And it really lays out the No Surprises Act very well. And this has been highly published. So it would be a good idea to show your front end staff as maybe a 2 or 3 hour training session. You can go through all of these steps. Part of it could be, and this is what our patients are seeing. This is some of the questions they may ask because CMS is directing them to say these things. So that's always good for them to kind of walk in the shoes of the consumer so that they can help answer those questions. Try role playing. Role playing is a fantastic way to get people prepared to have that conversation. It's one thing to talk about scripting. It's a whole other ballgame to have them walk through and actually use that scripting in action. It's really, really good, and it helps people really get that confidence, even if they're just going to use that same sentence every single time. Practicing that same response or that same sentence in a room where they feel comfortable really makes the difference. And then this, if you're not doing it already in our last bullet here, make sure that you do it, and not just for in the spirit of the No Surprises Act. Make sure that you're sharing your monthly denial reports. And this should show, your front end folks should know how many times the billers are having to go through and make those changes to the coverage. This is something that your folks is going to gain their buy-in on the front end. It's going to educate them. They don't need to know how to bill a claim, but they do need to know what the downstream impact is. And because we're recommending that you really watch your reimbursement and your denials on your out-of-network claims, it's important to share that information with your folks in the front end too. Get them geared in, get them excited about reducing things, and then maybe you guys can do a shared goal of reducing insurance change denials, for example, by 5% by Q2 or something like that. Get them, then you can kind of loop in some denial prevention efforts into this too. Get folks excited about that. So when we roll into our back end, so once again, make sure that they know about the No Surprises Act. Walk through your documented workflows, how to review the account, what it's going to look like, the reason code, or excuse me, the remark codes that are going to come through, how to recognize it when it is paid out of network on a proprietary paper remit. Try to give them as much information as possible. And then if you are going through the IDR process, if you're going to have it done at the financial class assignment level and not pull out a specific group of folks, that's totally fine. But give them some tools. Give them tools and teach them how to keep themselves organized, because everything has a time attached to it. So make sure that you don't miss out on opportunities, because it would be bad to go through the first 45 days. Once you get to the IDR process, you miss that 10-day window where you're supposed to upload your documentation, and then you have to accept that payment. That would just be heartbreaking, because it's so many steps that you have to do just to get up to that point, only to miss out. So make sure that they are educated on what that process is. Discuss that importance of validating what the patient balance is. Get them really familiar with those reason codes, with those remittance advices, what indicator is going to be used. If you work in Epic, use some billing indicators. Use billing indicators to track all of that stuff. And then you can pull reports from that. You can have work queues designed from that. They can pull queries. That's a really great way to keep track of all of these. And it's something that the team is used to using. And then emphasize the urgency to look at those payments. Help them have those negotiation conversations. So we've got folks that are basically, I call it dialing for dollars. I work follow-up. I also bill claims. I'm dialing for dollars. I may not be comfortable to have that conversation to say, hey, Primera, Blue Cross, I noticed that you paid this claim. You paid it about, 30% under. That's usually not a conversation that most of our billers are comfortable with or are used to having. They're used to checking on claim status, pushing back on denials, but they may not know how to negotiate that payment. And so making sure that they're comfortable with it, giving them some tools. It may be something as simple as an Excel spreadsheet that's got a formula built in that tells them they just enter in the charges, the charge information in there. Or maybe you have contracts loaded in your system and you can apply just kind of an overall commercial contract to that account. But get them comfortable with negotiating those payments with the insurance company. So our self-pay staff, once again, we want them to know what this act is. May not need to go into all of the detail like the IDR process and all that stuff, but you just want to make sure that they do know what the patient can or can't be billed for. Give them some instruction on how to look at EOBs. And so I'm sure even in self-pay, they're probably comfortable logging into the EOB system, looking at those, looking at the images, seeing how claims are processed. Give them a workflow to escalate the account. So should they go into the EOB and determine that it was not processed correctly, how can they put it on hold? Do you want them to put it on hold? How do they push that back to the billing department, the business office, to have them double check and push back to the insurance company? Enable those folks or empower those folks so that they know how to let that patient know, okay, we're going to take another look at this account, and then give them those resources to actually send that account back and which hold codes should be used, timeframes, stuff like that. It is important that the patient knows about the patient and provider dispute resolution process, because patients are probably going to bring it up. So if you are a provider that does give estimates right now to patients, and maybe with the software that you use, sometimes the estimates are off. If they're off by quite a bit, then this question is going to come up a lot. It probably already is. And so we need to prepare our customer service folks with some resources to have that conversation. What you don't want them to do is say, oh, all you got to do is go to this website and you can lodge a formal complaint. Okay, we don't want them to do that because this is obviously going to be reported at a federal level, because it's a federally sponsored website. And so we want to make sure that we are resolving these kind of in a private manner with the patient. And so that's when you give them that resource, give self-pay that resource to put that account on hold or escalate it to a supervisor to have another review made and talk to that patient about it. So role play and practice scripting. This is going to be excellent. Like I mentioned before, role playing is really a good way to really gain and build that confidence to be able to give a message to somebody that maybe it's not an entirely comfortable message, like, no, this is really a correct bill. Get them that scripting, maybe create infographics. So at HRG, we like to create infographics for our self-pay folks where it's really colorful, it's really nice, they can have it up and available, and it has specific scripting on there. And we tell them, feel free to read directly off of this scripting so that you know how to react in this situation. And we use it for a lot of common situations and phone calls and questions that we get from patients. So scripting and providing it with them, because some of this stuff, if a patient asks a question and they're not comfortable, then you lose that confidence and that call is most likely going to get escalated. Lastly, Reporting. So the beauty of working in revenue cycle is that anything is reportable, and that's nice, especially for the data junkies like myself. But you want to make sure that you have a handle on all of the information that you're going to need and get those reports built as soon as possible. So you want to look at your 835 reason and remark code mapping first of all. So this is a tedious task for anybody that has done it. You gotta do it on at least every 6 months or every quarter or so. You can't just work the exceptions because you want to make sure, especially if you have an automated workflow, that your 835, your reason and remark codes are built into the system and delivering the work to the right person at the right time. If you add in those NSA remark codes, then those are going to be delivered to the group that you want them to be delivered to. If you have automated workflow, you can have them bubble up and mirror a workflow like a denial because you want those to be seen right away. And then you're going to get on top of that 30-day time frame. But you also want to make sure that you're reporting this stuff. If you have the option of using a system indicator or maybe an agency or maybe a financial class, utilize that. Like I mentioned before with Epic, you can use billing indicators. There's lots of tools that you can use with the different hospital systems that are available out there. But what that's going to do is it's going to help you put together some reports where you can track your volumes, the payer information, your reimbursement, tracking the date that the claim was submitted to the insurance, and then the date that you received that payment. Because this turnaround time is 30 days and it's at the federal level. It's been at the state level for quite some time, but once it's hit the federal level, we can start to use that as leverage. And so I'm really going to make sure that I watch how long it's taking these folks to remit payment. Now, if it's 32, 33 days, okay, that could be the mail. I totally get it. But if we're talking 60 days out there, absolutely not. That's not going to work. And so we want to make sure that we're tracking that and then you're pushing back on that. And that could also be a little bit of leverage in the IDR process. There is no limit to the information that you can give to the IDR entity. And so if you spell out a bad, or if you can show a bad track record of reimbursing payments, then that actually could, the IDR could move in your favor. So it's good to track that information. If you are going to do the IDR process, reporting is going to be crucial, especially if you're kind of watching it to see if you actually want to implement the process, and then maybe you start on just a certain type of claims with a particular payer. That's fine, but make sure that you're tracking that. Track your success rate, track your the date and number of accounts, track all of that information to see if it's really worth it. How much manpower, how many hours are you spending pushing these through, uploading information? Is the IDR entity asking you for additional information 5 times every single one that you enter? Like what is our overhead cost of this? Really track that stuff to see if it's worth it, because I don't see that this is going to be going away anytime soon, but you may decide that you don't even want to do the IDR process because it doesn't make sense. Look at your weekly denial reports. Make sure that your payers aren't blanket denying out-of-network claims. I don't think the insurance companies are going to be ready for this. When I think back to all of the COVID testing and the COVID services back in early 2020, we were still receiving claims that were saying that there's a patient out of pocket for the COVID test, and they weren't supposed to process that way. There's a lot of behind the scenes programming and prep work that needs to happen for the payers. So it's possible that we may start seeing some denials. We may see blanket denials and it's not something that they're doing intentionally. So you want to monitor your denial reports and make sure that they're acting appropriately. And then lastly, take a look at your reimbursement percentages. Watch them very closely. Take a look at your in-network and your out-of-network payments to make sure that you have a consistent cash flow. If you start to see your in-network payers dip, that could be an issue with the adjudication system. Make sure that you're receiving the payments that you want to get and that it's appropriate. And that's something that, you probably already have your finance and your contract department already monitor this closely. But from a PFS level too, from a billing level, because you guys are the ones that are in a position to react quickly if the reimbursement starts to go in a bad direction. Okay, so we are right on time with about a minute to spare, and thank you so much for your time today, and we really do appreciate it. And like I mentioned, we had a readiness guide. It's also in the chat here. We're going to have all of that available when we share our slide deck and when we also share the webinar with everybody, the presentation. So thank you again for your time. There are a couple of questions. I'm going to go ahead and respond to these in an email because it looks like we only have about another minute for the rest of our slideshow today. So I don't want to take everybody's time up. So we'll go ahead and respond back to these privately. Have a great rest of your day. Thank you again so much.